Let me introduce a quick introduction of Dr. Sanjeev Sockalingam. He is a full professor in psychiatry and international leader in education and research. He's the vice chair of education at the Department of Psychiatry. He's also the vice president of education at CAMH, and it's a great pleasure to introduce him, as well as I'm thankful for his leadership overall for this conference. So Dr. Sockalingam, go ahead.
There you go. I've got to find the mute button always. Thank you, Raj, for the kind introduction. I have a couple of slides because I do see there's lots of questions and more that are coming in, but I wanted to frame these wonderful presentations from the morning thus far in the context of education, QI, and broadly within continuing professional development. So I have no disclosures, but just wanted to provide a little context for our discussion. So I'll briefly present for about 5 minutes and then give the rest of the time for questions. I just wanted to say it was wonderful to hear how far each of these programs have advanced in terms of our understanding of how to integrate data, quality of care, and specifically measurement-based care with the purpose of improving practice and learning. And this is a framework, some of you may have seen this before, just some early work that we were fortunate to do to build on many others around how do we bring together CPD and QI, or in this case, measurement-based care and improvement and CPD in terms of advancing our field and care progressively forward. I'll just highlight a few things that training, kind of adoption of a culture. I remember from Karen's presentation, she talked about bringing measurement-based care as part of the culture in the organization. Both Stefan and Marlene talked about implementation, red cap, individuals who are creating the data visualization and data collection methods and privacy, etc. So important pieces. And then the practice improvement, really navigating within those hospital contexts of multiple partners, the data flowing, and then the improvement opportunities for learning. And maybe I hope that we can talk a bit more about how do we bring learning into this. Brian Wang, who will be presenting the plenary later this morning, just published a recent article, which I think is a great way of kind of taking, in a very practical sense, what I just showed you on the last slide within psychiatry, but more broadly in quality improvement and patient safety. And really, if we're thinking about how do we start to assess our programs in terms of QI and patient safety and improvement in general and training, we can use this grid here to assess where our current programs or organizations are. So one is kind of, we aren't doing much in terms of intensity of quality improvement and patient safety clinical work or training. 4 is the ideal. 3 is we're really focused on training, capacity building, but really don't have the environments that are supportive of QI and patient safety. And then 2 is the opposite, is where we don't have enough training, but we do have quality improvement, patient safety as part of the key priorities in an organization. So this is kind of our readiness assessment, and I really like this tool that Brian and his team have put together. And I'm just going to share some brief work that David Wilger and myself and a large group of people, Ivan is also on this initiative, that really looks at going from the organization to the individual, and particularly relevant in measurement-based care, that we use data to identify our gaps and goals in our planning phase. We can use it to inform how we learn, and it could be formal learning, but it could be learning through what both Marlene and Stefan talked about in terms of resources, toolkits, decision aids, etc. We use data to assess how we're doing in terms of improving and making those changes in our practice, and then we further adjust. And this is much like a PDSA cycle, but this has also been called a kind of master adaptive learning cycle. And we've adopted this as part of a model for data-driven lifelong learning. I'll just show you that we did some data collection for psychiatrists, surgeons, and oncologists, and really identified that learning from our data was based on the perception of how useful data was, which is no surprise, the reflection on learning and building that in the culture, and the initiation of learning plans, being deliberate about our learning opportunities. And I think coaching and feedback, which was mentioned throughout this morning, is critical, in addition to having this embedded in a learning culture and environment. So in a program, hospital that really values these factors. And then lastly, I'm just going to say this is just some early work from our second phase of our research program. But I do think, again, it's quite relevant to what we're talking about today, that you know, within all the measurement-based care and feedback loops that are there to inform both quality improvement and practice change, there needs to be better trust about data, and how do we build that in terms of transparency, data quality concerns. There's a great article by Laura Cook that shows the cycle of kind of feedback of practice data and how people go through kind of stages of grief and kind of denial, kind of bargaining, and eventually acceptance. But really, coaching is critical to this. We also think about a team-based approach, and to Ivan's point, that this is not just about individual providers, and QI and patient safety is a team-based sport. And so how do we incorporate our teams in terms of initiating and reflecting on data and participating in data-driven changes? And how do we bring in new team members like data specialists to help us interpret and understand this data? Data visualization, as Stefan talked about, is critical, but how do we get people who can help us interpret our meaning of data at the clinical level? And then thinking about the multiple systems and layers in terms of data access, costs, and how can we be more efficient with that, and really continuous advocacy for data-informed learning, that really to build a kind of learning system, we need to break down the barriers of how we learn, and being open and transparent about our data, and feeling safe to share where we're not doing so well, and fostering curiosity and interest in trying to improve. And that's really difficult and does take a multi-layer approach throughout organizations or programs to achieve. So I want to stop there just to provide some reflections. I'm going to stop sharing and just come back to our panel here. Again, great discussions and talks. And I have to say, my disclaimer was I crafted these slides without seeing their presentations, and I just slightly modified them while they were, were presenting. But I have to say, I didn't have to do much, because I think it's really the inertia and momentum that's going forward. And over the last kind of 5 to 6 years, it's wonderful to see where there's greater possibility and enthusiasm. So really exciting times. So maybe I'll start off with one question for the panel, and then as people are letting this percolate, we have about 20 minutes. If you want to type in your questions in the Q&A, that would be wonderful. But I want to ask our three panelists a question about, how did you support or cultivate any learning opportunities, either for your individual providers or your teams within your respective programs? And Kieran, I know you do a lot of this work at Sunnybrook as well, so you can refer to a program or in general in measurement-based care. But any ideas on how you brought that into some of this work for that continuous feedback and improvement? So maybe I'll go with Marlene first.
Thanks, Sanjeev. And nice to see you. So you were saying, like, how did we incorporate learning for the team, like in terms of?
How did people learn from the data and actually start to incorporate that into their practice as part of that, those changes, right? As they're getting feedback and dashboards in your OCD program.
Yeah, so I think we took some different approaches. Like when the program started, we started to incorporate some of the initial data that we found into like team retreats. So people would really see like what was happening. Why were we collecting this? I remember giving like a talk on, QI and measurement-based care and the importance of collecting this. So the team themselves started to see they're not just handing in kind of packages for research that's happening at some other level. So I think that was really important for everyone to start to feel like this is all of our data that we're collecting. And I thought that was important for my team to be aware of. And that started to help, because then people started to think, well, this isn't just about me kind of handing something over and people are doing something with it, but this is also about like my clients. And then bringing it into the team meetings made a huge difference, because then everyone was looking at it. And then that extra step of bringing it into the progress review meetings, where I'm usually at all of them and the team treatment teams are there, and people being able to show it to the client and see their reactions and start to talk about it. I think all of that allowed everyone to feel that we all kind of own the data, if you will, clients and treatment team members alike. And this is all for us to be able to help the client and really kind of plan their treatment trajectory. So it was a process for sure, of education and I think time and comfort for people that maybe aren't as used to sort of thinking about data collection in that way.
Great, thanks, Marlene, and really highlighting the continuum of transparency and access and kind of feedback from patients all the way to the teams itself as a group and individuals. Thank you. Stefan, just wondering about the MDD ICP and how that worked. Oh, you're on mute, Stefan, sorry.
So we initially piloted this this work in a small group with physicians and two like psychotherapy groups, and so this was kind of where we learned how to use these tools, where we established this like IT infrastructure, where we met on a regular basis to discuss patient outcomes, but mostly also focused on the implementation and making things work, rather than using the entire dashboard and trajectories for like in the discussions. So and I think we have a bit of a different structure as well. We're seeing like large numbers of patients here. We have like overall like 25 physicians, I think close to 40 clinicians running different group programs, and so it's we have like divided these into smaller teams who meet on a regular basis and discuss cases, discharges, complex cases among MDD ICP patients, but also other patients, and we used we found that the teams and these small units were very helpful to communicate updates, new information, to have like an open discussion rather in a plenary of like 20 or more physicians, to really communicate the impact and the changes and how to use that, and do teaching as well on using the measurement-based care tools. So there are like four team leads, and we're from like the leadership, we're meeting with the team leads as well on a regular basis, and to communicate news and with we're still working on this implementation of this comprehensive dashboard, to really see and be able to pull up the complete patient trajectory over time, and hopefully that will come in the next few months. Currently, the measures are in the chart. The patients, the team, when discussing a patient, is using the information from the chart to see, okay, what is the improvement, where are the where are potential barriers for improvement, etc.
Great, thanks, Stefan. I think what you highlighted is it really segues also from Ivan's talk about you've created these smaller teams for learning. They're learning pods almost. For the data and dashboards, but they've actually invited more personal learning about cases and additional teaching, both formal and informal. So really creating trust, which was one of the barriers that I highlighted in some of the data that we created or collected. You found a way to try to overcome that in that model. So that's very interesting. Thank you. I'm going to ask Karen for comments as well.
Yeah, so I work on an inpatient adolescent unit, and it's sort of joined with the adult inpatient unit as well. And so over the last year, we've been sort of slowly migrating towards implementation of utilizing the quids in assessment of MDD patients. And sort of speaking to Marlene's earlier point that it takes a team effort and it's a multi-year process. So we're really at the sort of early stages of implementation of MBC in an inpatient context. And part of, I think, what has facilitated individual learning and team learning is sort of trying to understand what would be some of the motivational issues for physicians and clinicians to utilizing a rating scale. So I've sort of personally approached physicians, had one-on-one in-depth conversations about their philosophy of care, what are their hesitations around utilizing a rating scale, especially on an inpatient context, and really engaging them in terms of the implementation process. So seeing what is feasible. For outpatients, if you're seeing patients weekly or bi-weekly, it's still somewhat doable. When you're seeing patients every single day, physicians are probably going to complain that that's very burdensome to be assessing using a scale for every single encounter. So we've sort of decided that it would be on a mission, weekly, and then upon discharge. So similar to the intensive residential program for the OCD Center. The other thing that I think also has facilitated learning is just really encouraging a lot of education and training on the unit. So we've provided sort of nursing seminars on MBC. They are actually the ones that are facilitating the administration of this scale. It's been worked into their workflow process. So they know that when an MDD patient comes onto the unit, it's part of the admission process that they would get the scale, that they would sort of take it back. We also have an administrator to help us tally the data and then report it back to the physician as well. So as I mentioned, since it's still early days right now, we are going through multiple PDSA cycles. And I think one of the things that I'm really excited about is that we will be hopefully for the Department of Psychiatry obtaining a digital platform by the end of the year. So that's going to make it a lot easier for everyone to be entering their scores in, and hopefully we'll have the nice graphical displays that Marlene and Stefan have at their fingertips as well. And I think because of COVID, now that we're also utilizing iPads and laptops to even assess patients on the unit for virtual encounters, it's going to be a lot more easier, or I guess it's more familiar for clinicians as well to be utilizing that sort of platform to showcase information to patients.
So I think, again, just 3 points that you highlighted there. One is, it's part of starting up. It's a great lesson for all of us about understanding kind of implementation barriers and facilitators, but you're also kind of understanding what people perceive as useful as part of data, and also what's feasible within that context as well. And so it's fabulous, and you're already tackling the infrastructure piece in terms of the data and kind of aligning that with what's coming down the pipeline. So that's wonderful. And I think the last point is COVID has been a nice way, in one way. I mean, for all the awful things, the one kind of silver lining is I think about it as getting into that zone of proximal development, or that risk zone where we're optimally challenged, and we're kind of thrust into this, but with some support, and really it's allow people to test some of their fears or misconceptions about technology and data use. And so this is probably their great opportunity now to strike while the the iron is hot, kind of thing, so to speak, and kind of get things moving along in terms of measurement-based care. So that's great. I do see there's one question already, and again, if you have others, please type them into the Q&A and I'll get to them. But there were some specific questions, and Katerina asked a couple about caseload and the REDCap implementation, and if it's covered, and how the institutions or organizations make the REDCap accessible. So maybe this is for Marlene and Stefan to comment on. So I'll go to reverse order this time. So Stefan, so like, how is REDCap made accessible? And you mentioned your caseload, but if you could summarize that again. Oh, you're on mute again. There you go.
Thank you. I fear I cannot provide all the details. What I can say is that this was kind of we were lucky that this was provided by the institution. I don't know exact the details on the costs. So we have there is at CAMH is a research REDCap system, which is used for research projects, and there is a clinical REDCap system which meets the requirement for like privacy standards and everything, and that this can be integrated with the electronic medical record, and so that's the one we have been using for the clinical project. Though the MDD ICP is designed as a clinical quality improvement project, not as a research project, because we are not doing anything in addition what we would clinically do and what is already supported by current evidence.
And your caseload?
Unfortunately, I cannot say anything about the costs. We didn't have to pay for it. It's provided from the institution. But I can connect you with someone from our neuroinformatics team, the REDCap leads. They may be better able to answer the questions. And with respect to the teams, I have to say that we have a very diverse group of physicians in our clinic. So there are only a few full-time physicians working full-time in this outpatient clinic. Many do research work part-time or work in other areas, emerge bridging clinics. So it's difficult to say that there is a specific caseload per team. And physicians are also working, like it's calculated in half days in the clinic. So we ask physicians to balance their caseload for themselves with like seeing new consults and accepting patients into the MDD ICP for follow-up care. It's an episode of care, so it's not like ongoing psychiatric treatment forever. So it's the treatment that is proposed or like suggested and recommended within the algorithm. So there can be variations in caseload. So we had approximately like 20 new patients per month. So that's what I can say from like the consults. Yeah.
Thanks, Stefan. Marlene?
Yeah, for sure. So there was a cost. I don't actually think it was very much. It's like an annual license that we pay. Sunnybrook also has like I don't know, I've never really understood it. It's like there's like a person at Sunnybrook, like a department at Sunnybrook that is like the REDCap people that are at Sunnybrook. Anyway, so we speak to them. I don't know if I've ever actually met them, but they set us up with like a license that was, an annual license that felt, very reasonable. And it's kind of like a license per project, but this is such a big project that we're doing that it definitely felt useful. And the cost was affordable for sure. And they provide some, technical support too, and things went awry at the beginning and we didn't really know what they were doing. They were able to help us out. Mm-hmm.
Thanks, Marlene. And your caseload, just numbers?
Well, we have like in a year, I don't know.
Ballpark would be fine, I think. Just to put context 50, for people.
50 or 60 probably a year. So
okay. Yeah. Thanks, Marlene.
Yeah.
All right. I think from Katerina we've answered her questions. David, I also know that you work at Digital at UH, and I know many hospitals. I'm beginning to suspect or have REDCap units, so to speak, in their hospitals. I don't know, David, if you wanted to unmute just to comment on that as well, just because it's interesting, because that might be an opportunity to think about shared data and learning and to learn from one another.
Yeah, thanks, Sanjeev. I'm not the REDCap expert, but my understanding is that we I think had several instances and then have really moved to an enterprise solution and are working to an enterprise solution to have the protocols set up to have people access. So I think we're in the midst of rolling that out. I know there is a resource. It is something that we use, and I unfortunately don't have the costing, but I can find out for folks if they're interested.
Great. Great, thanks. Other questions for our panelists? If I do have one more if people don't, but I do not want to monopolize the discussion time. It's an opportunity for you to ask your questions. Go ahead, Raj.
Yeah, I had a question. I think it may, in relation to some of the other feedback as well, if I could ask your expert opinion on the panel about, this is such an important thing, measurement-based care being instituted in all organizations, but starting it up always has, and you guys touched on it, challenges in terms of getting people on board and sort of getting that process going. Whether it's, I think you mentioned it about paperwork or other challenges. Could you give us some tips about, from your experiences, on how you kind of, I think you mentioned, but I would love to hear a little bit informally about what you could do to get people on board and engaged in this process.
Well, going to go with, let's go with Karen this time. We'll start with Karen first, and then go to Marlene, Stefan.
Sure. I think the biggest tip is really investing in the people right from the get-go. And that means spending the time to cultivate those relationships, offering opportunities for their own professional development, and really fostering like a culture of learning. And so, as I mentioned earlier, like one of the first steps was having those one-on-one conversations. It was time consuming, but I think when, physicians and other interprofessional staff felt that their concerns were being heard and that the implementation plan would take their feedback into consideration, and that we were not just going to push this sort of on high, but really to sort of develop a local grown sort of solution to implementation. I think that actually facilitates the success of the program. So, and it is an iterative process. I don't think that there's one strategy that is sort of the take-all win strategy. There's going to be many different change ideas that have to be implemented slowly, adjusted, evaluated. And the other thing that I would say that has made it a little bit easier is applying for funding. So at Sunnybrook, there is an AFP Innovation grant, which we applied for, and we were able to secure monies for that. Because short of the funding, it's very hard to actually get somebody who's going to be responsible for managing the project and, managing the data, securing a digital platform, all of that. And the last piece, I think, is also networking outside of sort of the area of mental health, because there are many other experts, implementation experts, that have actually facilitated my understanding of how to overcome some of these barriers. And they've been very instrumental as well.
Thanks, Karen. All right, Marlene, next.
Yeah, so I echo sort of some of the implementation strategies that Karen has done. This is my second team where we've integrated measurement-based care, and it was much easier at Sunnybrook because we were a brand new team starting from scratch. Like the whole program was brand new when we started, so it was like this blank slate, and everyone was able to say, what do we want? And there was a ton of enthusiasm. The other team I was on was more similar to the process Karen's been describing, and that it's a team that's been functioning in a different way for a long time. So it was more kind of, the groundwork of really getting the buy-in and making sure that everyone was involved and understanding how it could be beneficial to them, and having different team members involved in different parts of the process. And I think that, and speaking to other teams more similar to that team, and figuring out how best to do it. So I think that engagement piece is critical. Small chunks are critical. Small packages of measures to start are really important. When people aren't used to like seeing a client sit there for half an hour, they might think it's really not the nicest thing to do. And I think showing that the measurement-based care is useful clinically is so important, because historically there was sort of this feeling that we're just collecting measures for research. So what does that matter for me? So then integrating that into actual clinical work that everyone's doing, I think brings it to life and just makes it such an important part of clinical care, rather than segregating it, which it shouldn't be, but in people's minds as if it was just for research. Not that that isn't important, but just kind of the way that people can frame it and understand.
Thanks, Marlene. And Stefan?
I think there have been, of course, a lot of barriers, and it is, and there was not enough time to talk about everything today, but I wanted to focus on some of the things we thought were like facilitating the implementation and the success. So I would say that the change in culture happened with the teams. And that was a crucial factor in the change in culture, and really like getting people out of their like offices, silos, and that was actually like many physicians were like suffering from that situation. So we could actually like with the new program, we could also address some of the concerns and the people working in the clinic and the team had. And the second part was like the overburdening like documentation. We were able to reduce the documentation time with integration with EMR and the self-reports, and like having like half the documentation of a progress note done when just entering the results that the physicians received from REDCap. So that was, I think, a winner, as well as the electronic infrastructure, which is convenient. There we're still like in the process. It's a continuous improvement process. We are like trying to improve things continuously. We have not, so we have like everyone has been using it at some point, but we are like working towards like a more comprehensive and full implementation in the clinic. There's, as you can imagine, with many thousands of patients per year and many physicians and clinicians, there's a lot of diversity and different interests as well, and a lot of things happening in addition to such a program in the clinic. So yeah, so I think these were the two main aspects of success, I would say, was that we could address pre-existing problems at the same time.
Great, thanks.
The implementation.
Thanks, Stefan. So I'm going to, again, wonderful thoughts and reflections, and just want to reiterate the momentum and just highlight also for those of you who are attending who may not be familiar with Department of Psychiatry and our strategic plan. Measurement-based care is one of the pillars, and these are presentations have really highlighted that and really provided opportunities for how we can think about learning within our clinical practices. And I do believe this is the future of both individual and team-based CPD. And so I really thank you all for great presentations and nice cohesion to our morning thus far. So thank you.
Thank you, Sanjeev and the panel. It was really an intriguing discussion and such an important discussion. You know, in many ways, I think so many teams and departments would be, this is the type of consult they would love, because having your expertise. I know there was one other question, and they can reach out and we can connect you in some way about rolling it out to large outpatient programs, which is happening, I think. But I will. They can contact Paula, and they can obviously contact you guys to follow up on that. So thank you again, and Sanjeev, for your moderation and guidance as well. Appreciate it. Just a FYI for everyone, we're going to probably give a 10-minute break. And so stretch break, washroom break, and then hopefully we can come back for a wonderful talk by Dr. Brian Wang. So 10 minutes for everyone to get a stretch. Thank you. One other announcement: all the slides and all those types of things. Paula mentioned that she will. It'll be. She'll send you a link and stuff for uploading things. To just an FYI. Thank you.